With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand, on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Hey, good morning, everyone. Happy Saturday. This is UroNurse, and I'm your host, Vic Senese. Glad to have you on board. You might have noticed over here, I got a QR code pointing somewhere around there. Go ahead and scan it. I'm going to have that on for a while. I'm going to explain what that's for, though, in a moment. Hey, if this is your first time checking us out, be sure to check out our website at uronurse.com. Best place to go to learn more about the show. All of our past episodes are there. Our audio version is there. Everything you want. Plus, all of our other great podcasts are available right from that site. And you can visit our advertisers who make this thing happen. So this week, got a great show for you. Today, we're going to explore. This is a CE recorded show, so you're going to be able to get one CE after this. But we're going to explore urothelial carcinoma and muscle-invasive bladder cancer. It's a rapidly evolving. Traditional platinum-based chemotherapy has long been a cornerstone of treatment, but a paradigm shift is underway. With the emergence of immune checkpoint inhibitors, antibody conjugates, and combination regimens, the first-line approach to locally advanced and metastatic bladder cancer is being defined. But first, here's what that QR code is for. Next week's episode is going to be on UroNurse. We're hosting our very first time a live virtual, I guess you can call that live, virtual conference for Chicago Metro SUNA. So it's the Staying Alive in Urology Nursing, a virtual conference hosted by Chicago Metro on November the 8th. That's next week. It's worth 4 contact hours, and you do have to register. It won't be played anywhere except on our website or through StreamYard. So you'll get a link that'll take you there if you want to check these things out. As you can see, some really great stuff. You should be flowing, chronic catheter issues with Todd Thompson. You should be dancing, restoring the rhythm of intimacy. How deep is your anesthesia? And more than a diaper, incontinence options by yours truly. So be sure to register if you want to watch this and get those for $10 for free conference credits. And here's a little promo for All right, so join us next week for that one. If you want to go back to the 70s, enjoy that disco feel. Our speakers for that have all kind of embraced the disco theme that we're going with, so it'll be a lot of fun. But let's get on with our show and take it away.
Hello, and welcome to this MyCME activity, changing the paradigm of first-line therapy for locally advanced metastatic urothelial carcinoma and muscle-invasive bladder cancer. I'm Dr. Daniel Petrolak, Professor of Medicine and Urology and Chief of the Genitourinary Oncology Section at the Smilow Cancer Center, Yale University. It's my pleasure to introduce Dr. Andrea Apollo, who is a translational researcher and medical oncologist in Bethesda, Maryland. The goals of this program are to review, discuss, provide expert clinical perspective, and to educate all members of the multidisciplinary care team on the optimal approach to first-line therapy for patients with locally advanced or metastatic urothelial carcinoma and how to safely and effectively incorporate that knowledge into their real-world clinical practice. To help us achieve these goals, we've also been fortunate to be joined by Ken, an actual patient who will share his journey and help us deepen our understanding of this disease and its impact on quality of life.
Hi, I'm so happy to be here. Thanks for having me.
Hi, I'm Ken Brothers. I'm happy to be alive and happy to be here.
So this is a very, very exciting era in the treatment of urothelial carcinoma. And immune checkpoint inhibitors have really made a huge difference in our management of these patients. So how do immune checkpoint inhibitors work? We know that cancer cells develop many mutations that can make them appear foreign to the immune system. T cells can recognize and attack these foreign antigens, and cancer cells have developed a way of immune attack by expressing PD-L1. Adaptive tumor expression of PD-L1 also can turn off the immune system, and clinically, what we'd like to do is to block that and to reactivate the immune system. It's almost like if you think about the TV show Star Trek, the cloaking device, where you're uncloaking these evil cells and allowing the immune system to recognize them. PD-L1 plays an important role in dampening anti-tumor response and immune response. So one of the more exciting findings in urothelial carcinoma is the fact that antibody-drug conjugates have significant activity in urothelial tumors. We know that Nectin-4 is expressed in nearly 90% of urothelial cancer specimens, and this is the target of the drug enfortumab vedotin. Enfortumab vedotin binds to Nectin-4. This complex is internalized and then cleaved, and an antitubulin agent called monomethyl auristatin, otherwise known as MMAE, is released into the cell and disrupts microtubules. Microtubules, of course, are important to cellular structure, and by disrupting the cellular structure, cell death occurs. So you can actually deliver significant amounts of this particular agent to the cancer cell, which in the other situation, if you gave MMAE freely to patients, you can't achieve the concentrations. In fact, it's very, very toxic. So this is a novel mechanism to deliver anti-cancer drugs to the cancer cell.
So, just like Dr. Petrolak was saying, EV is by itself active in urothelial carcinoma, and checkpoint inhibitors are active in urothelial carcinoma. And when we put them together, we should expect additive effects. But we're actually, with EV plus pembrolizumab, we have seen possibly some synergy. And the question is, how does this happen and why is this happening? Well, the payload, MMAE, is a highly potent cytotoxic agent. And it's an analog of other, like dilastatin also. And there's been in vitro studies to try to understand what the synergy is. So MMAE is a microtubule destabilizing drug. And what that means is it's basically inhibits the polymerization of tubulin, which is like the skeleton of the cell to form the microtubules. And when in vitro studies have been done with human dendritic cells, exposing them to this MMAE, which is the payload of EV, you can see that you get an immune modulatory effect that can potentially then is co-stimulating molecules to enhance T cell stimulation. So perhaps because of this immunomodulatory effect, you're getting an enhanced immune effect when you add the checkpoint inhibitor. And there's a lot of studies ongoing right now that are kind of trying to understand this a little bit better, and a better understanding of the complementary mechanisms of EV plus Pembro will then help us build on this therapeutic effect and then target mechanisms of resistance too. And this is really important for the clinical trials that we're going to discuss that have been doing that have been combining checkpoint inhibitors with these antibody-drug conjugates that are so effective. So there are two studies that I'm going to talk about that really, one of them did this, and it's the combination of EV plus Pembro, and this is the EV302, and it combined enfortumab vedotin plus pembrolizumab, and this is in the frontline setting for patients with metastatic urothelial carcinoma. And then we have the Checkmate 901 study, which is something that we have been kind of doing for the last couple of years, is to try to improve upon the first line treatment of metastatic urothelial carcinoma, which for decades has been chemotherapy, platinum based chemotherapy. And in this study, nivolumab was added, but not to any platinum, specifically to cisplatin combination with gemcitabine. The other studies have also incorporated carboplatin, and so far they have been negative. And we're going to talk about the negative studies, but these are the two positive studies that have really changed the treatment landscape for metastatic urothelial carcinoma. Dr. Petrolak, did you have any comments about these?
No, I think that these are very, very exciting trials, and I think that this is the next step in the future. And I think that one point that you made about cisplatin is that there may be a difference in synergy between immune checkpoint therapy and cisplatin versus carboplatin. And I think this is one of the unique aspects of the nivolumab study, Checkmate 901, that it's limited to cisplatin, and you may not see the same effect when you combine checkpoints with carboplatin.
Yeah, that's a great point, and I'll kind of allude to that a little bit later. So if we want to look at the EV302, this is the schema. It's a randomized study. 886 patients were randomized. These are patients with metastatic urothelial carcinoma or bladder cancer, and they were randomized to receive either enfortumab vedotin plus pembrolizumab or chemotherapy. And the chemotherapy could be cisplatin plus gemcitabine or carboplatin plus gemcitabine, with the dual primary endpoint of progression-free survival and overall survival. And these are the progression-free survival curves. Here we see a median improvement in progression-free survival. For the patients that received EV plus Pembro, it was 12 months, and of the patients that received chemotherapy was 6 months. So basically doubling of the progression-free survival. And then when we look at the subgroups, which are the groups that did better with one treatment versus the other? All of the subgroups did better in terms of progression-free survival with the combination of EV plus Pembro. When we look at the overall survival, that is really impressive in terms of what we've had for decades. Again, the platinum-based therapies have been the standard. And here we see that the median overall survival is a little bit more than a year for patients that are getting platinum-based chemotherapy. This is 16 months. And when we look at the EV plus Pembro arm, this is doubled, almost 32 months, 31.5 months for patients getting this treatment. So just like Dr. Petrolak, you were saying, this is really very exciting finding that has really changed the landscape of urothelial carcinoma. And when we look at the subgroups in terms of overall survival, we used to divide the patients by whether they can receive cisplatin or not. And the patients that can receive cisplatin often did a little bit better, but because enfortumab vedotin and pembrolizumab can be given to patients that have good or poor kidney function, then you don't really have to divide these patients anymore. So whether you were cisplatin eligible or not, the patients did just as well and did better with the combination of EV plus Pembro compared to just chemotherapy. And then when we look at the PD-L1 expression, which is a target for the pembrolizumab, we see that it didn't matter whether the target was high or low. Both patient groups did well with the combination of EV plus Pembro. And when we look at the entire subgroup analysis, all the subgroups within this trial, again, we see that this is rare that we see, all the bars are in the left-hand side, which is the EV plus Pembro arm, showing that the study favored the combination of EV plus Pembro. And this is important here. This is the overall response rate. And why that's important to me as a medical oncologist is because I want patients that have tumors for those tumors to shrink. And this is the tumor shrinking by 30%. And what is the percentage of patients that we're seeing this in? 68% in the EV plus pembro arm versus 44% in the chemotherapy arm. So this is really important in that we saw an improvement in overall response rate in terms of tumor shrinkage for the patients getting EV plus pembro. And when we look at the complete response, that means that the tumor completely goes away in radiologically. That's 29%, almost 30% for the pembrolizumab arm versus 12.5% for the chemotherapy arm. So these numbers are very impressive. And you know, when we first saw these outcomes for this study, it was very exciting to see this. Dr. Petrolak, did you have any comments about that?
Yes, I think you've made some excellent points about this particular trial. Firstly, in some data that Jonathan Rosenberg has actually presented at the ESMO meeting, in the past, we always thought you needed to hit the home run, a complete response to see a survival benefit. With this combination, even those patients who have a partial response, they still have a very good chance of surviving at 5 years. And from the phase 1 trial, 40% of patients are alive at 5 years, and that's really remarkable. The other thing I think that's important to point out is when you look at the hazard ratios, patients with hepatic metastases do really as well as those patients with lymph node-only disease. And that's a big change. Chemotherapy
Yeah.
really didn't work well in those patients in the past.
Those are the poor
And I think that
the patients with
very,
liver
very
metastasis.
poor prognosis,
Yeah.
absolutely. And these patients now are actually responding. I've got patients from the 103 trial that are complete responses out 5 years with liver metastases. Same thing with EV as a single agent. So this drug has really transformed the treatment of metastatic urothelial carcinoma.
Yeah. And then, you know, what about the toxicity? So we know that it works. How, you know, what are the side effects of these of this combination? And it's a unique side effect profile. You have skin rashes, which is overlapping again with the checkpoint inhibitors. But a unique side effect of this drug is you have peripheral neuropathy, which can be sensory or motor, and that's the microtubule inhibition, the MMAE payload. You can have ocular disorders like dry eyes, and we think that that's from the nectin target that it has, hyperglycemia. So, you know, caution in patients that have uncontrolled diabetes or high sugars. And in some instances, you can also have infusion-related reactions. So at this GU ASCO 2025, we saw updates from the EV302 presented by Dr. Powles, and similar to what we had already seen, EV plus pembro, again, superior to chemotherapy. The hazard ratio was 0.51, and the median follow-up for this follow-up was 29 months, with a median duration of response of 23 months, and versus 7 months for chemotherapy. And the durable efficacy, there was no new safety signals, reinforcing EV plus pembro, again, as a standard of care for patients in the first line setting. So this follow-up data, again, reinforces that EV plus pembro is the standard of care. So Dr. Petrolak, did you want to say anything? Otherwise, I was going to move on to the Checkmate 901 study next.
No, I think you've done a great job in presenting all this data. I mean, it's very, very exciting. And I think what's also exciting is the follow-up is consistent with what the original presentation is. And so we're looking forward to seeing more follow-up on this trial.
Yeah, no, that was nice to see the longer follow-up. So the other study I wanted to talk about that was also a positive study is the Checkmate 901 study. And this is a combination of nivolumab plus gemcitabine and cisplatin. And these are, again, patients with metastatic urothelial carcinoma or bladder cancer. And the patients are randomized to receive either the chemotherapy, cisplatin, and gemcitabine alone, or with nivolumab. And they get an induction period, and then they get, because the chemotherapy is 6 cycles. And then after they're done with the chemotherapy, they continue the nivolumab by itself. And these are the primary endpoint was overall survival, and these are the Kaplan-Meier curves showing an improvement in overall survival going from 18.9 months in the chemotherapy arm to 21.7 months in the combination group with the checkpoint inhibitor. So, it's positive, but not as strikingly positive as the EV plus Pembro study. And of course, both of these studies were presented at the same session in the same meeting. So it was interesting to have them there and to be able to kind of discuss them and compare them. So again, we saw doubling of the overall survival with EV plus Pembro, and here we're seeing a modest increase in the overall survival of about 3 months. And in terms of the response rate, the shrinkage, the tumor shrinkage, we're also seeing tumor shrinkage here that's higher than what we normally see with chemotherapy. With the cisplatin gemcitabine combination, it was 43%. But when you added the nivolumab, we got it as high as a 57.6%, and almost 22% of those patients were a complete response. So, very positive findings. And if you're presenting this data by itself, it would have been very, very exciting. But because it was presented at the same time as the EV plus Pembro, it got overshadowed by those results. Dr. Petrolak, did you want to talk about the Keynote 361 study?
Yes, thank you, Dr. Apollo. I'd be happy to do that. So Keynote 361 is first-line pembrolizumab, chemotherapy, or both in advanced urothelial carcinoma. This is a phase 3 study where they took patients with unresectable or locally advanced metastatic urothelial carcinoma, and that included upper tract disease. And these patients were randomized to one of 3 arms. This could have been Pembro plus gemcitabine cisplatin, and carboplatin could have been substituted for cis. And then patients then received pembrolizumab maintenance therapy for up to 29 cycles, pembrolizumab alone, or gemcitabine with either cisplatin or carboplatin given every 3 weeks. The primary endpoint was progression-free survival as well as overall survival, and secondary endpoints were objective response, disease control rate, and safety. So this slide summarizes the survival data from Keynote 361 when we compare the pembrolizumab arm to the chemotherapy arm. As we see at the 12-month benchmark, there's no difference in overall survival, with 61% of patients versus 56% of patients are still being alive. If we look at overall survival in chemotherapy in those patients who have versus pembrolizumab in those patients who have high levels of PD-L1 with a CPS score of greater than 10, there's also no difference between the arms.
So that was pretty disappointing, I would say, Dr. Petrolak, because we really were hoping pembrolizumab is such an active agent, and we were hoping that when we combined it with the chemotherapy, we would see an improvement in overall survival. And just like you showed it didn't show that. And then this study here, the IMvigor130, that one actually was the first study that was presented doing the same kind of strategy, which is adding the checkpoint to the chemotherapy. And this study, the IMvigor130, is a randomized phase 3 study. Again, this is all in metastatic, the first-line treatment of urothelial carcinoma. The patients were randomized to 3 arms. The combination of atezolizumab plus chemotherapy, the combination of just atezolizumab by itself was the second arm, and then platinum-based chemotherapy, and it could be gemcitabine and cisplatin or carboplatin and gemcitabine. And the primary endpoint was comparing the combination with the chemotherapy by itself. And unfortunately, the outcomes of the overall survival in the intent to treat population, although numerically higher, not statistically significantly higher, with a median overall survival of 16 months versus 13.4 months for the patients in the chemotherapy. So this was really disappointing. I remember I was the discussant for this abstract when it was first presented, and I was really hoping to see an improvement when you added the the um, the immunotherapy to the chemotherapy. So these are the current NCCN guidelines, and because of all the trials that we have shown you, really EV plus Pembro kind of took the the first prize for being so incredibly more active than what we have been used to with monotherapy, with platinum combination. And although the Checkmate 901 study with nivolumab plus gemcis was positive, it was modestly better than the chemotherapy compared to the EV plus Pembro that doubled the overall survival, progression-free survival, and response rate. Dr. Petrolak, did you have comments about the NCCN guidelines now for first-line
Yes,
metastatic?
I think it's important to note that the number of patients who would not be eligible to receive EV Pembro are fairly limited. Uh, those patients who may have peripheral neuropathy are those that you may not want to treat up front. Those patients could receive carboplatin gemcitabine. Those patients with diabetes that may be difficult to control, as well as those patients who are not eligible to receive immune checkpoints and have prior autoimmune disorders. So those are the patients I would say that you would not choose EV Pembro as first line, but again, they're very, very limited.
Yeah, and just to kind of emphasize that a little bit, now that if you're giving EV plus Pembro in the first-line setting, I don't know if there's value in giving another checkpoint inhibitor in the second or third line setting. So really the use of nivolumab plus gemcis is going to be very limited, just like you said. So if you're giving the pembrolizumab already with the enfortumab vedotin, you look at here and you look at the second line options. A lot of them include a checkpoint inhibitor, but if you've already used a checkpoint inhibitor, we don't have, as of this point, evidence that using more checkpoint inhibitor makes a difference. So I usually use chemotherapy as my second line, and we can talk a little bit about that more as we go along.
Right. We don't have any guidelines at this point as to how to select patients. I mean, certainly we do have molecular markers to select those patients who have an FGFR mutation. Unfortunately, sacituzumab govitecan has been, with its accelerated approval has been withdrawn, and that's an option which I thought was very reasonable to give patients. But you're making a really, really good point about the checkpoint inhibitors. And if these agents move up into the neoadjuvant setting, I think it's going to cause a complex problem as to what to do when a patient relapses. Do you reintroduce a checkpoint at that particular time? Is there a time dependency? There are a lot of very, very interesting questions that are going to need to be answered.
Yeah, no, great point. So I think with that, we can move on to the discussion from these abstracts and from the findings in the first line setting. So I can start off by saying, for me, the goals of treatment in the first line setting for urothelial carcinoma is I want to shrink that tumor. So that's why the response rate is important to me. And I want that shrinkage to last. So I want durable responses. Of course, I want longer overall survival. And I want to do this with minimal toxicity. So those are my goals in the first line treatment. Dr. Petrolak, what are your thoughts about that?
I agree completely. First line treatment is a little bit complex in its management because one of the side effects that we see with our patients is neuropathy. And that can be long lasting in some patients. What I think is most important from some data that I presented last year at ASCO with with single agent enfortumab vedotin is that dose intensity be maintained in the first 2 cycles of treatment. That seems to correlate best with overall outcome in terms of response. You can dose reduce patients later on due to toxicity without compromising their overall response or survival. And I think that patients really do want to continue. And I think part of this is a negotiation between the patients, between toxicity and a potential outcome. Patients don't want to stop if they know that something's working. The other thing, too, that it's important to point out is most of our responses are very rapid, and you can see improvement in bone pain and other parameters that may indicate improvements in quality of life fairly quickly within the first cycle or two. So you have a very good indication that the patient's responding even before you may go forth and do scans to see if there's been objective response.
Yeah, yeah, great points, Dr. Petrolak. And on the topic of shrinkage, um, looking at what we normally see or we're seeing with chemotherapy. So I'm taking in these graphs, I'm taking the control arms, the chemotherapy control arms from the phase 3 trial. So these are more modern control arms using gemcitabine, carboplatinum, or gemcitabine and cisplatinum from the IMvigor130 study, the one that we talked about with atezolizumab, the Keynote-361 that Dr. Petrolak talked about with pembrolizumab, and the EV302. And we see that the response rates are very similar, ranging, it's about 44%. And then when we specifically look at the cisplatinum, which we think those patients respond a little bit more, we do see that it's a little bit higher, going all the way up to 50% in the IMvigor 130 arm. And then when we look at the carboplatinum, we see that, it is a little bit lower, about 41%, 42% for the patients getting the chemotherapy, the gemcitabine and carboplatinum. And then when we look at the EV302, we see that the response rates are so much higher, with a response rate of 68%. So, very exciting findings. And again, the Checkmate 901 was also positive, with an overall response rate that is higher than we had seen, but not as high as we saw with the EV302. And putting these all together, we see that EV302 has the highest response rates. And one of the important things that Dr. Petrolak alluded to, it also has a high duration of response, and the time to response was short, both for the EV302 study with EV plus Pembro and the Checkmate 901 study with nivolumab plus gemcis. The time to response was about 2 months. So that's the first restaging scan. So seeing these responses quickly is important, especially if the tumor is causing pain, and you wanna alleviate that pain, that tumor burden, as quickly as possible. Dr. Petrolak, did you have any comments about that?
No, I think you've made some really excellent points. I think that also too, if they don't respond in that first scan, don't be discouraged, because we do see late responses as well.
Yeah.
But the pain is impressive. I mean, I've seen patients go from being on narcotic analgesics to rapidly discontinuing them. So it really does make a big impact on quality of life.
Yeah, agree with that. So when we kind of put it all together and we look at the overall survival, I'm giving the prize to EV plus Pembro because it has the most impressive overall survival. And we just also talked about the follow-up now, that these findings have remained consistent with longer follow-up. And the combination of EV plus Pembro was FDA approved in December 2023 as a first-line treatment for urothelial carcinoma. Now, what about the Checkmate 901 study? Well, we talked a little bit about it, that it did improve outcomes, but and it is FDA approved. It received FDA approval in March of 2024 as a first-line treatment. But when we look at it and we compare it to the IMvigor130 and the Keynote-361s, all of these studies had the same strategy. They took chemotherapy and they added their checkpoint inhibitor. So why was the Checkmate 901 study positive compared to the other studies? Well, when we look at it in more in detail, we can see here that the InVigor-130 study included also patients treated with carboplatin, which has a lower response rate, and the same thing was true for the Keynote-361. Another point that I wanted to bring up was, well, what about maintenance checkpoint inhibitor? Maintenance avelumab had been the standard of care. So we talked about the standard of care had been platinum for decades, but then we saw that if the patients that responded to the platinum chemotherapy, if you gave them maintenance checkpoint inhibitor, and in this case, the Javelin Bladder 100 tested avelumab, we saw an overall survival benefit for those patients, and that had really transformed the field. And we were, before waiting until the patient developed metastatic disease, we started giving everybody maintenance checkpoint inhibitor. So the question was, well, can you does it make a difference if you give the checkpoint with the chemotherapy and include all the patients, including those that don't respond to chemotherapy? And it's really hard to compare these two studies, the Checkmate 901 and the Javelin Bladder 100, because they had different populations. The Checkmate 901 included also patients that had that did not respond to the platinum-based chemotherapy, and the Javelin Bladder 100 had included only those patients that responded. What do you think about that, Dr. Petrolak, about comparing these two trials?
Well, there's clearly patient selection that's going on with the
Yeah.
Javelin 100 bladder study. That's really important to note. The question is, I think several points are made from your presentations. Number one, is there a difference in checkpoints? As we know, atezolizumab has been withdrawn for its approval because it actually, from all the phase 3 trials that have been performed with it, never showed a survival benefit. And that includes second line, that includes adjuvant therapy after radical cystectomy. So there may be a difference in checkpoints. But the maintenance therapy issue is an interesting one because you are selecting patients. And the overall survival of avelumab plus best supportive care, that does not include the 3 to 4 months that these patients are on chemotherapy. But again, it's patient selection. So it's eliminating those patients who may have visceral disease initially, who may not respond to chemotherapy. Those patients will go on to a checkpoint as second line, at least according to those trials. And this is, I think, where the importance of giving EV Pembro up front is. In treating those visceral disease patients, you are not allowing them to progress, which they may have progressed on chemotherapy. So I think that the maintenance is important. Keeping these patients on checkpoint is important. But of course, the induction therapy is different in all of our trials.
Yeah. So what about the next thing I wanted to mention is, what about the perioperative space? And there's a lot of activity right now in terms of clinical trials that are being developed to kind of move these therapies, like Dr. Petrolak had mentioned earlier, to earlier states of disease. Because right now we're giving platinum-based chemotherapy, and if we saw that EV plus Pembro is better than platinum-based chemotherapy in the metastatic setting, can we move this to an earlier state of disease in the perioperative setting and try to cure these patients earlier? And there's a lot of studies ongoing asking this question. There's the EV-304 study that gives neoadjuvant EV plus Pembro versus platinum-based chemotherapy, and adjuvant also EV plus Pembro versus observation. There's the Volga study with EV plus durvalumab and tremelimumab. That's one arm. Another arm is an EV just with durvalumab, and then there's a maintenance component to it. If you got the durva and the tremi in the neoadjuvant setting, you get that in the adjuvant setting also. If you got the durva in the neoadjuvant setting, you get the durva in the adjuvant setting. So that study is ongoing right now. We saw some early reports of safety from this study at ESMO last year, but we're still awaiting the final clinical results. There's also the EV-303 study with EV plus Pembro, and versus pembrolizumab for patients that can't tolerate cisplatin, and that study is also ongoing right now. So I think a lot of exciting trials. Dr. Petrolak, did you have any comments about that?
So I think that there are several important things to note from these studies. Firstly, we have generated single agent data with enfortumab in those patients who are cisplatin ineligible and as neoadjuvant therapy. And we see a very, very similar pathological complete response rate to that of cisplatin-based chemotherapy. So this is room for excitement, of course, because now you're adding the checkpoints in with these particular trials. But there'll be questions that arise from these studies. Number one, in a patient who has a pathological complete response, do you need to continue treatment after they are demonstrated to have this? And then, of course, will there be more toxicity engendered by giving these patients more EV or more pembro after their initial cystectomy? Remember, I mentioned before that you may not need to achieve a complete response to see that survival benefit. Well, the same analogy may be seen with neoadjuvant therapy as well. And then, of course, what are we going to do with our patients who do progress after neoadjuvant EV pembro or EV checkpoint? And that's going to be an important question for clinical trials. So we've sort of shifted the field to the left by moving these treatments up earlier and are engendering other questions for research later on.
Yeah, and I think that's going to be an important question. Do you need both the neoadjuvant and the adjuvant part? Do you need surgery? Can you skip the surgery? Can we go for bladder preservation if the patients do have a complete response? Those are all unanswered questions right now that are going to be really important for quality of life for patients. But we want to do it safely because we don't want patients to then develop metastatic disease if that could have been prevented with a surgery, with a radical cystectomy, which is our standard of care right now. So I think with that, we can move on to the next section.
So there have been presentations looking at patient-reported outcomes from the phase 3 EV pembro trial versus chemotherapy. And Dr. Gupta has led the way on these particular presentations. And there have also been studies that have looked at evaluating oncologist practice patterns and decision-making locally advanced and metastatic urothelial carcinoma. It's the U.S. Physician Paradigm Study. So current challenges with first-line use of immunotherapy plus enfortumab in first-line or locally advanced urothelial carcinoma. We know that there are studies that have looked at patient-reported outcomes for enfortumab versus chemotherapy in the EV302 trial, which look favorable for enfortumab vedotin. Same thing looking in the evaluation of oncologist practice patterns in decision-making in those patients who have metastatic urothelial carcinoma. The question comes into play as to whether chemotherapy should be used versus EV pembro in certain patients with metastatic urothelial carcinoma. And some of the predictors of toxicity in patients are uncontrolled diabetes, underlying cutaneous disorders, underlying neuropathy, or morbid obesity. There have been some criteria that have been developed looking at this. These have not been prospectively evaluated, but something called AVITA, which is EV ineligible criteria, which are patients who have a high hemoglobin A1C greater than 8% or baseline glucose of 150, grade 2 or greater sensory neuropathy, any corneal or retinal adenopathy, a creatinine clearance, a glomerular filtration rate of less than 45 milligrams per minute, and an ecolic performance status greater than or equal to 2.
I have a comment about this. When these criteria came out, it was in the form of an editorial, and I thought that it was a little early for criteria like this to be coming out because we don't really have prospective data on a lot of patients that have comorbidities. So my feeling is that we really need to, and I know they weren't included in the trial, right? Because the trial has eligibility for safety reasons because of toxicity, but I think we need to learn how patients and how to treat patients that have these comorbidities with these drugs, because you saw the doubling of the overall survival. If we can provide these therapies in a safe way to more patients and not try to build a criterion that, if you have these comorbidities, you can't get this therapy. I think we need to learn how to use these therapies in these patients so we can provide them the best care possible. So I didn't agree with this criteria. I think that really what we need is more experience in patients that have certain comorbidities so we can learn how to use them better.
I agree completely. And I think that the important thing with managing toxicities is having a team that's trained to talk to the patient, to pick up early neuropathy or other issues, to partner with an internal medicine physician or primary care doctor to help manage diabetes. And also in situations where patients may have ocular dysfunction, to partner with an ophthalmologist. I've actually treated successfully some patients who are on hemodialysis with EV Pembro, have had really remarkable responses with it. And I think that we just, as you pointed out, we need better guidelines, more data to help us understand those patients who may have some difficulty with these particular treatments. So, for example, as you said before, grade 2 or higher sensory peripheral neuropathy was an exclusion criteria for all the EV trials. Well, we need studies that look at how we can manage these patients, because that's the real world. And perhaps big data is the way that we can actually sort this out.
And then if the ECOG if the performance status is being affected because of actual tumor, is giving the active therapy may improve the performance status. So ECOG-2 is another criterion that I'm not sure I particularly agree with. And I used to be very hesitant to treat patients that were very frail with EV plus Pembro, but as I've gotten more comfortable with it, I now give it, and I used to give a lower dose, but after seeing some of the data that you presented, that perhaps giving a higher dose is maybe better and the patients do better in the long run. I've started, because it's a chemo, right? So the nice thing is that it's a weekly chemo, so we can always dose adjust. So starting a little stronger earlier and then dose reducing as needed has been my go-to strategy. And again, it's evolving the way that I'm treating patients, and I'm becoming more comfortable with it. And now even my more frail patients, I treat them with full dose, and then I dose, and then I back off. I dose reduce as I go.
I could give you a specific example. There was a patient who was entered on EV 103 who was very symptomatic from his hepatic metastases, and was actually sort of reluctant to sign up on the clinical trial because he really was not feeling well. This man is now tending his garden in Stamford, Connecticut. He has a little bit of neuropathy, but this is 5 years out. He's doing great. So I think that the important thing is you discuss all the options with your patient and all the possibilities. And there are some patients that will not do well, but this needs to be discussed, because some of the responses we've seen here are quite impressive, and patients are able to live a good quality of life, despite the fact that they may not be in the best of shape when they start treatment. Given these considerations that we just discussed, I think it's important that we discuss with a patient what their experience has been in the real world with EV Pembro. So, Dr. Apollo, you'd like to interview Ken about this particular issue.
So Ken, it's so great to have you on this discussion board. Why don't you tell us a little bit about your bladder cancer journey?
Thanks, Dr. Apollo. I'm an unusual patient in that I feel like I've straddled from the days where leeches were used to the current immunotherapy. I was diagnosed with bladder cancer 14 years ago. And my baseline scan for metastatic disease was negative, and I started GemCis on a neoadjuvant basis back in 2012. But after 3 rounds, my scan found that I had positive nodal involvement. And so in May of 2012, I had a radical cystectomy and prostatectomy and had a neobladder constructed. And since then, played cancer whack-a-mole for quite some time. I met Dr. Apollo at a BCAN event in 2012, and she has followed my case since then. And I've become active in the bladder cancer community, in the Bladder Cancer Advocacy Network. I've been a member of the Bladder Cancer Task Force through NIH and have been a patient advocate for 14 years in counseling other patients and caregivers. I have gone through 4 remissions in my bladder cancer journey. And the first remission was triggered by my surgery, in which all of the 12 positive nodes were removed. Then it was watchful waiting. After a year, I had recurrence, and I had dose-dense MVAC chemotherapy.
So just to interrupt you, Ken, right there where you had the recurrence. Yeah. So you had recurrence, you had metastatic disease. Well, tell me what affected your decision regarding the treatment options that you had. Did you have treatment options back then?
My options were, immunotherapy was not an option at that time.
Right.
And as you and I had talked, and I talked with other doctors, the name of the game was just suppressing the cancer, the tumor growth, and to slow the development of the disease. And there was a debate about whether I should have a radical cystectomy once the cancer went metastatic. But the consensus was get rid of the engine generating the cancer, which was my bladder, and it was confined to my lymphatic system. And so I had that surgery done, 61 lymph nodes removed, 12 of which were positive. And then we went into watchful waiting. And after about a year, I had, and scans every 3 months, I was found positive for nodal activity in my neck. And so we decided to go with dose-dense MVAC, which I do not recommend to anybody. It was a painful and traumatic type of therapy, but it succeeded in deferring the tumor growth. That lasted for about a year.
So Ken, just going back to the time where you were trying to decide about the dose-dense MVAC, or that was recommended, what was important to you at that point? Shrinking the cancer, you didn't have any pain. You had a tumor, but really cancer-related pain wasn't really a big issue. What about the risk of severe treatment-related side effects, minimizing those? What were your priorities at that point?
To prolong my life.
Yeah.
I was 49 years old when I was diagnosed. I had 4 children at home, married, and I knew that the odds of my long-term survival were bleak. The data showed that I had about an 80% chance of dying within 2 years, 95% dying within 5 years of metastatic cancer. And I understood that. I retired from my practice in intellectual property law and focused on my family and wanted to have time with my family. And dose-dense MVAC was identified by you and by others as probably the best available treatment to help suppress the tumor development. And it worked for about a year. After dose-dense MVAC, I was able to take a 5-week trip to Europe with my family. And that was a price I was willing to pay. Meanwhile, we knew that immunotherapy was being developed. And Dr. Paulo, through your intervention in early 2015, I was one of the first bladder cancer patients enrolled in Johns Hopkins nivolumab trial for a single agent checkpoint inhibitor. And within 12 weeks, had a complete response. All of my tumors could no longer be detected on the CT scan.
When you started the immunotherapy, how do you feel it impacted your quality of life, and what side effects did you encounter?
Oh, it was a dramatic improvement. At the time, I had tumors growing on the side of my neck that were bulging out and beginning to press in on my nerves, my carotid artery. And they were growing at the pace of about 1 centimeter a month. And so I was in active tumor growth. Radiation was not an option with the location of those tumors. So immunotherapy was a moonshot to keep me alive, because I knew if it didn't work, I'd be dead soon. And compared to chemotherapy, immunotherapy was a breeze. I had virtually no side effects. And I had very little GI issues. And to feel, and as a matter of 12 weeks, having those tumors disappear, it was like magical. This was a wonderful thing. And so I credit you with getting me in the trial that saved my life. So I thank you once again. I continued with that trial for 2 years. Even though I had no evidence of disease, the data was still unknown as far as how long I should continue immunotherapy. And at the end of the trial, after 2 years, I went on surveillance. And that lasted for 18 months. And then the tumors returned in 2018. And after some consideration and debate, we decided to go back to the single agent checkpoint inhibitor. And this time it took nearly 3 years for the tumors to be eliminated. And in fact, I had one persistent tumor at the base of my neck that I had to have radiation therapy on. And that was in June of 2020. Since then, I have had no evidence of disease. And this June will be coming up to my 5-year mark, which I think is remarkable. I did not expect to live this long. And I attribute it to the immunotherapy.
Ken, thank you so much for sharing your story. It is a remarkable story, and it's always wonderful to hear. I had a question also. You because you have been through this journey, even while you were going through it, you shared your story. You had a blog. You've been a patient advocate in a lot of different forms, through BCAN, through the NCI Bladder Cancer Task Force. And I know you talk to a lot of patients. How would you describe the patient's experiences with EV plus Pembro versus platinum-based chemotherapy?
Yeah, EV plus Pembro is a game changer. It is what I consider to be the new gold standard therapy for approaching metastatic cancer treatment. The data is so promising. And I tell patients that if they can qualify for it, and if their comorbidities do not disqualify them from EV plus Pembro, that they should get on it as quickly as they can and ride it as long as they can. There are risks of side effects that I think it's important that the patients fully understand that. They are not as dramatic as the side effects I experienced with dose-dense MVAC, but patients do need to be informed of that. Frequently, I find that patients can't stay on the regimen as initially recommended, and they have to have breaks. So preparing patients for that is important. I've counseled patients who fear that because they're feeling some adverse effects, that it's not, that somehow their progress is being reversed. And I say, this is a normal consequence of this drug regimen. Stay with it. Don't lose faith. Continue to stick with it. And it's so important for clinicians to continue to reassure the patients, knowing that this has such a high degree of success compared to the earlier therapies. It's not perfect, but it is the best available option today.
I agree with that. And another question I have is, do you occasionally talk with caregivers about their experiences? And do you think that these experiences as caregivers get impacted by all the different types of therapies?
Caregivers feel like they are drinking from a fire hose while they are trying to absorb all of the data, take care of their loved ones, and juggle all of the information. And looking around, so many caregivers are on social media, whether it's Instagram or TikTok or whatever, and they're getting all of this conflicting information. And they're wanting to grab onto something that seems to be available to them that will be the magic cure. And it's so important. And what I try to do is say, stick with the science and stick with the data and talk to your clinicians and understand that the proven course, especially with EV Pembro, is going to bring your loved one the greatest chance of recovery. And but the conflict that caregivers have between family members and social media and the conflicting information is pretty stressful. And that's not taking into account financial toxicities or the uncertainty of whether the disease is going to be put in remission.
Thank you so much. This is a great discussion, and it's really wonderful to have your perspective as a patient and as a patient advocate. So we're very grateful for your experience and your candor in discussing your life and what you went through.
I have kept a list of therapies as I've been on the committee and as I have known that there's a likelihood of relapse, hopefully becoming less and less likely. First, it was single agent nivolumab, and then it was ipilimumab with nivolumab, and then there was EV, and then there was EV plus Pembro. And I still keep that list. And if there comes a point where my cancer reasserts itself and single agent checkpoint inhibitor isn't going to work, EV plus Pembro is going to be my drug of choice.
Well, hopefully we won't need to use that list.
Yeah, I share that hope. And so grateful for all of the doctors and the researchers who have developed these drugs and have enabled my life to be extended and preserved. And there are so many patients and caregivers out there who, after hearing this dreaded news of their loved ones having cancer and especially metastatic disease, to have the hope that EV plus Pembro can bring is a wonderful thing. Let me ask one question. A couple of patients recently who have had weight issues and had diabetes have asked me, can I go on a GLP-1 drug and then have EV Pembro?
Yes.
I have no idea what the answer is.
Dr. Petrolak comments, but yes.
I've actually had one or two patients on GLP-1s have done fine.
Yeah.
So that would be, it would help to control the diabetes without question. And I think that, as we also know with patients who may be challenged as far as weight is concerned, that there is a cap to the amount of EV that these patients can receive. So I think that we have to be cognizant of that. But I think that that's a terrific idea. I don't have a lot of data on this, but I've been able to safely treat patients on those agents.
Yeah, me too.
Well, good. That gives me some information to communicate back to the patient community.
Dr. Petrolak, I'll take it back to you if you had any additional
Terrific.
questions.
No, I mean, I think that Ken has really outlined the patient journey and how important it is to talk to your doctor, to communicate regarding clinical trials that may be available, to discuss all toxicities, what the risks are, what the benefits are, and then tailor the treatment to the individual patient. And I think that that's where our future lies. We now have agents that now do improve survival with a significant improvement of quality of life, and that's not the way things were 20 years ago. Certainly we only had MVAC at that particular point, and Gem-Cisc followed after that. So now we can offer patients hope, and it's great to see that Ken is doing very, very well.
Yeah, and like we said, I think the biggest question now remain is, can we bring this to earlier states of disease? And what does that mean for subsequent therapy? So I think we need to develop trials to answer, do we need to give it pre and post-op? Do we even need the surgery? And if patients do undergo the therapy in the muscle-invasive setting, what happens in the metastatic setting? How do we treat those patients? And we do have other therapies available that are active. What is the best sequence of these therapies? I think there's a lot of unknowns right now as the whole landscape is shifting.
This has been a terrific session. We've seen how the science has developed over the last several years, and we've seen the impact and the importance of clinical trials on actual patients. And Ken's story is very, very compelling. And we all have many stories like that in our clinical practices. So, Dr. Apollo, would you like to summarize some of the findings that we've come forth with on this particular program?
So I think one of the key takeaways is that enfortumab vedotin plus pembrolizumab is an extremely active combination. It improves overall survival compared to platinum-based chemotherapy, and it's now the first-line standard of care for patients with metastatic urothelial carcinoma. There are some toxicities associated with it. I think one of the most, to me, treatment-limiting toxicities is peripheral neuropathy. There's also some sensory neuropathy, hyperglycemia in patients, also caution with patients with diabetes. And we didn't talk a lot about gastrointestinal events, fatigue. There could be ocular toxicity, rare pneumonitis, skin reactions. So there are side effects that we have to be cautious of. But I think we need to learn how to manage patients that have comorbidities with EV plus Pembro because of its remarkable anti-tumor effects. A lot of questions remaining as to, how do we sequence therapies after EV plus Pembro? How do we target mechanisms of resistance of EV plus Pembro? And then how do we incorporate it into earlier states of disease like the perioperative setting? So I think still a lot of questions that we need to answer in our research.
I think it's important to note that our work is not done yet. We know that from the EV-103 data that there are 40% of patients who are alive at 5 years. We want to go to 100%. And that's the important thing. So the questions that you outlined, drug resistance, when to sequence these patients, what's the minimal effective treatment that we can use that will minimize toxicity and maximize efficacy? What about some of the other targets that are coming out? HER2/neu, different agents that are being delivered, such as the topoisomerases. There are a lot of new drugs, and the question really is, how do we sequence them? So thinking about this from a historical standpoint, I was fortunate to spend my fellowship and the beginning part of my attending career with Dr. Alan Yagoda, and think of how far we've come from the MVAC era to now. We can offer our patients hope and new treatments and the ability to live long lives. And that's really, I think, what it's all about. In summary, I'd like to thank Dr. Apollo for her insight, thanking Ken for his experiences, and also, importantly, thanking the patients who volunteered for these clinical trials over the years. Without their bravery and support, we wouldn't have been able to make these advances. So thank you again.
No, thanks for
Thank
having
you.
me, Dr. Petrolak, and Ken, great to see you.
Thanks.
Good to see you too. Thank you.
Terrific.
Well, there we have it. It was a great episode. I think it's really promising for those that are dealing with cancer, metastatic cancer nowadays, to have these options available. So be sure to visit UroNurse to get the code to go and take the afterwards test. You'll have to do the pre-test and the after test, and then you'll get your contact hours. Here's that code again. If you want to scan the QR, just a reminder again, next week we'll be starting at 8 a.m., not 9 a.m. It'll only be available through StreamYard. So you have to register. You'll get a code in an email that'll take you to the StreamYard site. You can watch it through pretty much every browser now. And you'll be able to watch the entire episode, and then you'll get a QR code at the end of the episode that'll allow you to go to take the evaluation and get your 4 contact hours for only $10. So we hope to see a lot of you next week. But if you're used to tuning in on all the other channels like YouTube, Facebook, LinkedIn, all those, we're not going to be live on any of those channels. We're only going to be on the one because, again, we're doing this new thing. We're trying to be a little proactive with offering a virtual conference, and we're combining with Chicago Metro to do that. So see some of you next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.